Hello, my favorite Homo sapiens, and welcome back to another episode of Resolve the Evolved. I'm your host, Molly O'Brien. I hope you enjoyed last week's episode called You Think Men Are Sexual Animals? Wait Till You Meet Bonobos. We have another super exciting conversation ahead of us today. Episode is called It Feels Like I've Been Pregnant Forever, so why is it only 9 months long? Our discussion today is going to focus on introducing, analyzing, and comparing two unique hypotheses regarding the duration of modern Homo sapiens pregnancy. First, I will introduce the opposing theories, the obstetric dilemma and the energetic gestation and growth hypothesis. Then, we will give a warm welcome to this week's special guest, OBGYN Dr. Katie Hoff, who has so graciously offered her time and expertise in female physiology in the pregnancy realm. Dr. Hoff will provide some insights and professional opinions on the matter to help further our understanding and discussion. To begin, the obstetric dilemma, also referred to as the OD, suggests that the duration of pregnancy is roughly 9 months due to the anatomical restrictions of female pelvic sizes. Additionally, the explanation it offers for female pelvic sizes being the limiting factor is the result from bipedalism being selected for, which keeps the pelvic width of modern humans at a certain size. Essentially, what this means is that because humans walk on 2 legs, and that's what's ideal, our pelvic size and shape has been evolved for to become narrower than before. Sometimes this leads researchers to say that babies are born prematurely, because if they could grow bigger in the womb, they would, only if they could spend more time before the pelvic size became the limiting factor. Further on that note, some believe that because of the misconception that pelvic size causes premature childbirth, there are underestimations of the female body, leading to unnecessary use of childbirth interventions, like C-sections. Some evidence that disputes the OD theory states that increased pelvic size would not lead to decreased mobility and a need for higher metabolic processes for bipedalism to continue, which is stated in the obstetric dilemma hypothesis. On the contrary, there is also supporting evidence for the OD theory, which believes that pelvic size, as I mentioned, is the constraining factor in childbirth. The OD hypothesis has been studied frequently, and there are controversial thoughts on its validity. Meanwhile, other studies and scientists have focused on different hypotheses, one that has some competing arguments. The energetic gestation and growth hypothesis, also known as EGG, introduces the idea that the constraining component of pregnancy length is the metabolic levels of the mother. After roughly 9 months, the childbearer reaches a metabolic ceiling and can no longer provide sufficient nutrients and resources that the fetus needs to survive in the womb. Some evidence that has been used to help justify this theory is the idea that the placenta consumes some of the energy that is traveling from the mother to fetus, therefore causing the metabolic rates of the mother to be pushed further. Therefore, the mother does reach a point where they can no longer sufficiently provide for the baby. On the other hand, it has been noted as refuting evidence that infants who are breastfed by their mother are at least as much, if not more, metabolically demanding than fetuses. While both sides of this theory have evidence to support their claims, it is hard to strictly justify one over the other. In a similar manner, it's hard to kind of reconcile both of these popular competing theories. So, why don't we take a moment to get a professional opinion on this topic? All right, welcome, Dr. Hoff. First, I just want to thank you for your time today. Super excited about picking your brain around such interesting and debated hypotheses. Why don't we begin with you telling our listeners a little bit about yourself, your medical background, and your current practicing role.
Yeah, thanks for having me. So I am an OBGYN. I work for Kaiser Permanente in Los Angeles. And I graduated OBGYN residency a little over about 3.5 years ago from USC, and I've been practicing with Kaiser ever since. I went to medical school in Wisconsin at Medical College of Wisconsin, and that's pretty much my medical background.
Awesome. Thank you so much. Well, we are excited to have you here. So, I guess just to kind of get the conversation started about pregnancies and childbirth, things like that, how often, like in your practice, do you deal with those kind of things? I guess fertility in general as well.
Yeah, so just about every day, I do everything. So as a obstetrician and gynecologist, I do about half OB and half GYN. So, my clinic days, I'm, either seeing pregnant patients for their prenatal visits. I'm seeing people before they're pregnant for fertility issues or preconception counseling. And I see them after birth for their postpartum visits, and then for lots of GYN issues as well. So it's about every day, and then I take call once a week where I'm just in the hospital for 24 hours delivering babies, whatever comes in. Usually deliver about 5 to 7 babies per call.
Okay, wow. That's awesome. So, yeah, so you're pretty familiar with these sorts of things, which will be awesome for our conversation today. And so, I guess another thing I was curious, would you say that it's common knowledge that pregnancy typically lasts 9 to 10 months? I know you're an experience as a doctor, but also being a mother and kind of just through that. Was that something that typical knowledge, would you say?
Yeah, I think most people know that, the human pregnancies last for 9 months. And, as an OB, it's a little different because I feel like most people, when they're pregnant or, people talking about pregnancy, talk about it in months. But as a doctor, we really talk about it in weeks. And so a full term pregnancy is 40 weeks, and that is what your due date is at 40 weeks. But the full you're considered full term once you hit 37 weeks. So anywhere babies are typically born anywhere in that 37 to 40 weeks. As you probably have heard, a lot of people go past their due date, and it's a common recommendation that we don't let them go too far beyond their due date. And so my common practice is to induce delivery at 41 weeks. So that's about as long as we let pregnancies go.
Okay, gotcha. Yeah, that makes sense. I'm sure you probably see a wide range as well, just with the position you're in. Um, and so, I guess the basis of the podcast today is just kind of going to be surrounding, like, trying to understand and explain why pregnancy duration is what it is. I'm sure you are familiar with a couple different hypotheses that have tried to explain this, but today we just want to focus on two theories that offer kind of differing and competing um, like propositions for this. So one is the obstetric dilemma hypothesis, also known as OD, and the other is the energetic gestation and growth hypothesis, simply EGG. I kind of introduced these earlier in the podcast, but if you, with your position, if you could just give a quick, brief description of each of these for our listeners, that would be great.
Yeah, so pretty briefly, just the obstetric dilemma is stating that babies are actually born prematurely because of the physiology and the anatomy of the mother, with the pelvis as the limiting factor. And then the energetic gestation and growth hypothesis um, is kind of targeting that the limiting factor is more that the metabolic demands of the mother can no longer effectively provide adequately for the baby beyond the 9 months.
Okay, great. So I guess given that information for our listeners here, what are your like personal thoughts on why the pregnancy lasts the 40 weeks that you say it typically does, um, and I guess just from your own opinion, how would you kind of take those?
Yeah, so the 37 to 40 weeks is really in a sweet spot, and I think both of those theories have some component of truth and are probably both right. So, from delivering babies, I can see that, the maternal pelvis really couldn't, you know, handle babies much larger than what they are at full term. Even with how they are, some babies are needing to be born through C-sections for what we call CPD, which is cephalopelvic disproportion. So meaning the pelvis is too small or the head is too big. So, the cervix stops dilating and the labor is arrested. So I think that kind of goes along with the obstetric dilemma, seeing how, this happens pretty frequently at full term, that some babies just aren't able to be born naturally in a vaginal delivery. So if they were to go months longer, we can all imagine this would happen much more frequently. We also see, a big component of the energetic gestation hypothesis coming true, in that, the placenta really starts to give out past that. That's the main reason why we induce at 41 weeks. It's not as much due to the size, but it's really due to the placenta giving out. So the first sign that we see of that is something called oligohydramnios, which just means the fluid is low. So the amniotic fluid index is something we kind of keep track of in the full term babies, and we're making sure that doesn't drop, because that's kind of the first sign that the baby isn't getting enough to make proper amount of urine, which is mostly what the amniotic fluid is made up of.
Okay, wow, interesting. So it kind of sounds like it's not necessarily a debate whether one hypothesis is right and one is wrong, but more so just kind of finding justifications that each of them have some validity, and there's kind of a way to, in a sense, say both are right. Would you agree with that?
In my opinion, yeah, I see validity in both of them. We see the 40 weeks is there for a reason. Seems like moms can't really push out a baby, much farther beyond that. And it sounds like, from our experience, that babies really aren't meant to stay in much longer than that as well.
Right. Okay. Makes sense. So I guess knowing this, are babies born prematurely, would you say? I mean, they're so dependent for the first months and even years of their lives. Is that normal for that to kind of just be the way that human, the human body works?
Yeah, so I think that that's our normal. That we wouldn't call it prematurity, because we just kind of hit this sweet spot. 37 weeks is considered full term because that's when the lungs should be developed. That's really what we're waiting on. Why we wait past that point is most things are developed, and the last thing that we're kind of waiting on is that lung development, is the last step that we need. And we found that, 37 weeks, the lung should be developed. By 39 weeks, we're almost, with good dating, we're pretty positive that lungs are developed completely, and they'll be fine, not needing extra oxygen or anything supplemented after birth. But I wouldn't call them premature, because before that 37 weeks, we definitely see the prematurity where babies need more than just their mother to help take care of them.
Okay.
But
yeah.
we refer to humans versus other animals. Yes, it's very different in the care that human infants need compared to other mammals, where they come out walking and, are pretty self-sufficient at birth. Humans are not at all. They can't even roll. They need their mother for everything. And so, in that sense, yes, when you compare humans to other mammals, they are, lagging in their development.
Right. Yeah, that makes sense. So yeah, just kind of some interesting information there, considering like what are normal, how that differs from other species and things like that. So I guess does this give us any information or insight regarding like the evolution of childbirth? I know humans clearly have changed a lot physically and anatomically over the past several centuries, but like what can we learn from our current understanding of pregnancy length, just from your perspective?
Yeah, I mean, it could. It's it's hard to say exactly. I think that we have evolved to find this sweet spot. That being said, there's lots of things that do go wrong with pregnancy, and we do unfortunately still see lots of preterm deliveries for whatever reason, whether it's an insufficient cervix or preterm labor or the water breaking too early. All of those reasons, and those babies needing extra help. But I haven't personally done as much research into uh, how long gestations were going on hundreds of years ago. I would expect that they had more preterm deliveries and they had more post-date deliveries because there was less intervention with C-section. And there was less, there's certain things we do to help avoid preterm deliveries now that they didn't do back then. Medicine has advanced a lot. So I think the biggest thing that it has changed is, neonatal and maternal deaths. I don't know how much it's changed, the timing of the evolution as much.
Right. Yeah, interesting. And I mean, definitely the way medicine has evolved, um, even just in the past couple decades, has been crazy, and proven to be very beneficial, especially for females in childbirth. So that's good to hear. I guess one other question I was just curious about, do you think female bodies currently function in a way that promotes like safe and proper fertility, pregnancy, and childbirth?
Yeah, I do. I think it's amazing what they're able to do. Um, you know, women are able to carry these pregnancies, even twin pregnancies and triplet pregnancies, which really always kind of blow my mind when I see that, and how they can accommodate that. And then, even with the deliveries, it's pretty amazing to see what the human body can do. I do think that there's a couple components that make it a little bit harder. I think that there is, increased maternal mortality that I don't know if you've been hearing about recently. That's been, discussed in the OB field, and I think a lot of that is the health status of our patients nowadays. There's a lot more obesity and advanced maternal age, which is older women having babies, which, we see a little bit of a component of the placenta giving out a little bit earlier in these older moms, which kind of goes along with the, kind of the energetic demand that at that age they're unable to support the pregnancies as well. But for me, I see the biggest factor is in the obesity that we see, really having a lot of extra risk factors of things I'm not sure if you've heard of, such as preeclampsia and gestational diabetes, and making these moms pretty sick and can cause some issues. So I think it's really important to really keep childbearing women as healthy as possible at a correct weight, and eating healthy and exercising, so that we can have healthy moms and healthy babies.
Yeah, definitely. It's, to me, it is crazy what the female body can do, and the way it has functioned and continues to function for all of us. And so keeping an eye out for those couple of changing trends is something I encourage all the listeners to kind of take note of. Um, Lastly, do you have any sort of advice for mothers or young females who are interested in kind of having a better understanding of what the human pregnancy process is like, and kind of how to be most aware and ready for that when it comes to be?
Yeah, so, I think there's, lots of things you can do. You can talk with your doctor if, you have certain questions, either you're the OB or a pediatrician. If you want a good book that can tell you some things about pregnancy, There's a book by Emily Oster, who's actually, she's not a physician, but she's um, an economist who's done a lot of research, and her book is called Expecting Better. Um, and it has a lot of good facts about pregnancy, and just kind of, what's the things you can do and can't do. It's kind of more for really when you're thinking about becoming pregnant or actually pregnant, kind of like what you can do, what you can't do to have a safe pregnancy. But it's a really good resource for some people. I've had a lot of patients comment on really liking, and a lot of friends. But otherwise, I think important if you're in your childbearing years, like I said, just staying healthy, staying active, um, and listening to your doctor, because we will walk you through the process. It's a fun process, and it's a very exciting time.
Awesome. Well, I really appreciate that. I know the listeners will as well. And yeah, that kind of sums up our talk today. So I appreciate your time. I know you're very busy being, a doctor and a mother yourself. So we thank you for, squeezing some time in today to talk about some of these important issues with me.
Yeah, of course. Thanks for having me.
It was a pleasure working with Dr. Hoff the past couple days and being able to get a fresh professional perspective on these interesting theories. As you can tell from today's discussion alone, evolution is not something that only our ancestors can relate to. It is part of our lives in so many ways. Learning about how we function in relation to how we used to function and how we will function in the future can be critical, not only from a health and medical standpoint, but from the view of the greater community. So, keep an eye out for ways to gain knowledge about yourself, your ancestors, your neighbors, and everyone in between. And don't forget to subscribe to your favorite biological anthropology podcast, Resolve the Evolved. Thanks for listening. See you next week.